Hello, hello. Very nice to meet with all of you. I have with us right now Dr. Leisman, Dr. Kelly. Dr. Leisman will be presenting tonight about the danger of anxiety during pregnancy. Dr. Lebovitz is with us. He is also one of the founder and chairman of the Mental Wellness Society. He's also my partner. We have Dr. Kelly, who is also our partner. She's a neuroscientist and neuropsychologist, and she is the chair of the education and parenting of the Mental Wellness Society. Sherry, where are you today? Are you in Florida or are you in Connecticut? You're muted.
I am in Florida today. Thank you for asking. It's wonderful to be here.
Okay, great. Dr. Lebovitz, you are in Pittsburgh?
Yes, I'm in Pittsburgh. Glad to be here as well. And I'm very keen on hearing what we all have to say.
I'm in Israel, but not in the same city as Leisman. So, Dr. Why don't you start with the program?
Okay, it may not be a half bad idea if we all muted the microphones other than me. So if we can have this slide show on. Good evening. We're going to be talking about things that aren't necessarily immediately apparent, and I'm not getting into any political debates about how much a fetus knows and how much it doesn't. But we'll see that there's certainly a symbiotic relationship between the fetus and its mother. And so if I can have the next slide, please. Let's take a look at the overall issue of the Yerkes-Dodson law, which is a representation of the relationship between arousal and performance. That what's optimum for the human being is a moderate level of arousal. We can call that anxiety as well. They're interchangeable terms in this case. So too little anxiety in most people is not exactly a motivator for production and for work. Too much anxiety is the same. Too much anxiety can also be labeled as stress. And so what we're looking at is the issue of stress, and first of all, we're going to need to define it. So if I can have the next slide, please. We're going to now take the Yerkes-Dodson law and look at it in terms of human behavior. So on the leftmost portion of the slide, you see boredom, and the rightmost portion, breakdown and burnout. And both of those states are not exactly good states, but the optimal state is not on either one of the edges of that continuum, but rather, actually not a continuum, the inverted U-shaped curve. But optimal stress is somewhat in the middle. You can have the next slide, please. So we have a problem with the issue of stress, and it's essentially a defining problem. I'm sorry we can't do animation of this slide, so there's a lot of verbiage in here, but I'll try to work through it. One of the problems with stress is that it had been defined by Selye in the 1950s as anything that's perceived by the organism as being physically and or psychologically injurious to it. We do not make a distinction, especially in terms of the history of this field, between that which is physiological or physical and that which is psychological, because at the end of the day, everything is going to wind up physiological. So stress, unfortunately, is an ambiguous term defined by Selye as, again, anything that's perceived by the organism as being physically and or psychologically injurious to it. Why is it ambiguous? Because it really doesn't tell us much about adaptation or maladaptation, and we need something that's a little more biologically oriented for us to be able to perhaps hang our hat on what we're trying to pull out as it relates to maternal-fetal relationships. So Sterling and Iyer in the 1980s had introduced the term allostasis to refer to an active process by which a body responds to the daily events and maintains homeostasis. A word about that. And we're going to be using the word allostasis or allostatic load and overload as we proceed through our chat today. What we can say is that if there is a heavy allostatic load, formerly the term stress, it will have an effect on the level of cortisol that's produced in all of our cases, and especially in the case of the pregnant woman. So the first thing we're going to see is an increase in the level of cortisol. The second thing is when that happens, it's highly associated with emergency reactions. That is, an increases in heart rate, respiratory rate, fibrinogen level, which is blood clotting factor, blood sugar level, because you're priming the body to be able to disappear in the case or run away from expected stress. Can I have the next slide, please? So stress can be classified in a number of ways, and there are 4 types. There's good stress, as we had already seen from the Yerkes-Dodson law. There's tolerable stress, which we can get away with it. There's distress, and finally toxic stress, and we'll have something to say about each of those terms. When we're talking about the difference between, I'm going back to Sellier's original term, we're going back to looking at the difference between a stressor and stress. A stressor is something that we encounter pretty much every moment of our lives, either physically and or psychologically. When someone rings the doorbell, there's a stressor. If someone is yelling at someone else, that's a stressor. The key factor or the key difference between a stressor and stress is time. So that if you have anything that's perceived as being physically and or psychologically injurious to you over prolonged periods of time, it's the time factor that increases the cortisol level, the blood clotting factor, the blood sugar level, the respiratory rate, and so on and so forth. We call them emergency reactions. So good stress is a term that's used to the experience of rising to a challenge, to healthy self-esteem, to impulse control, all of those things that we need in order to adequately function during the course of the day. Tolerable stress, and it's actually stressor, refers to situations in which negative events occur, but the individual, with resilience, has a healthy brain architecture that allows him or her to cope. Distress, on the other hand, refers to the uncomfortable feeling of the type of the stressor and degree to which the individual feels a lack of ability to influence his or her outcome. And finally, toxic stress refers to situations formerly known as stress itself, in which negative events are experienced by an individual who has limited support and brain architecture, and therefore has a significant difficulty in being able to adjust to the trials and tribulations of life. It's where we have a heavy allostatic load in the term that we had just applied. Next slide, please. So another way of looking at Sellier's general adaptation syndrome is in terms of time. That if we take a look at time, with short periods of time, we recover pretty quickly. When we are involved with a heavy allopathic load over moderate levels of time, we do rise to the occasion. You can see an increase in the curve. Finally, with extended periods of time, we then see a drop in our ability to cope. And that's resistance to stress that winds up as exhaustion. And invariably, in normal, healthy adults, we find that there is a difficulty or an incapacity to be able to handle the stress. We usually get sick. That's why we see a lot of college students, for example, who not during, but after exams, have a tendency to become ill because the stress or the allopathic load had been heavy for them over prolonged periods of time. Next slide, please. Let's get to the next slide. So, in order to effectively cope with stress, and I'm using this as background before we even get to the issue of pregnancy and the fetus itself, is the issue of resilience, which is our ability to cope with the setbacks, adversity, and traumatic experience of life. In being resilient, we can say that it's a necessary function for our well-being. And a misconception about resilience is that it is definitely not that you won't experience any difficulties. Rather, it refers to how you manage those difficulties. So resilience is a concept that helps one's personal growth and gives us a better and newer perspective on life. Next slide, please. Let's go on to the next slide in the interest of time. So there are specific brain structures that are involved in one's capacity to adapt, typically sitting in and around the area of the amygdala, and we'll describe that in a moment. The amygdala, by the way, is a preferential activation point for teenagers. Their frontal lobes haven't quite developed yet. We will talk about that on another occasion, but not right now. But the amygdala is part of the brain that's most responsive to emotional behavior. So any kind of emotional behavior is triggered by the amygdala, considered to be part of the limbic system. And the neurons which extend from the amygdala are triggered to or associated with fear and stress. The next slide, please. And this is a video, and rather than me going through the neuroanatomy on the subject, let me present this to you in shorthand.
Welcome to 2 Minute Neuroscience, where I simplistically explain neuroscience topics in 2 minutes or less. In this installment, I will discuss the amygdala. The amygdala is a collection of nuclei found in the temporal lobe. There are 2 amygdalae, one in each cerebral hemisphere. The term amygdala means almond, referring to one of the most prominent nuclei of the amygdala that has an almond-like shape. The major nuclei of the amygdala include the lateral nucleus, basal nucleus, accessory basal nucleus, central nucleus, medial nucleus, and cortical nucleus. Each of these nuclei can also be partitioned into subnuclei. One common scheme for anatomically organizing the amygdala is to divide it into a basolateral region, made up of the lateral, basal, and accessory basal nuclei, and a corticomedial region, made up of the cortical, medial, and central nuclei. There are, however, other common ways of anatomically dividing the amygdala as well. The amygdala has traditionally been considered part of the limbic system, a group of structures linked to the processing of emotions. The amygdala has historically best been known for its role in processing fearful emotions. When a threatening stimulus is present in the environment, it is thought that the amygdala is also involved in identifying it as a threat and initiating a fight or flight response to it. More recent evidence, however, indicates that the amygdala is active during the processing of positive stimuli as well. Thus, it is now thought the amygdala's role is more complex than that of a threat detector. It may be involved with assigning positive or negative value to stimuli, and with the consolidation of memories that have a strong positive or negative emotional component. It is also still being explored in a variety of other behaviors, ranging from addiction to social interaction. Thus, its functions are diverse and still not fully understood.
Next slide, please. And the slide after. Slide after that one. Here we go. This then, one before. This then brings us into the issue of neuroplasticity, which is what we're trying to do is we're trying to create circuits that are more optimized and effective in having the human being get through the day-to-day tribulations of day-to-day activity. It's even more important for the fetus and the pregnant woman, and we'll explain why. So resilience then implicates the notion of neuroplasticity, which is the probability of neuronal endings, of dendritic endings, being able to articulate with each other to create networks. And that's highly, highly flexible and malleable. Resilience also involves mechanisms that promote flexible adaptation to changing conditions, the capacity to persist towards long-term goals, and that is, resilience implies neuroplasticity. Next slide, please. So, plasticity relies on neurobiological systems that support flexible adaptation. Bonding exudes the greatest neuroplasticity in mammals. By bonding, I mean maternal-child bonding. Neuroplasticity led to the evolution of viviparity, which is internal gestation, and to the physiological changes in mother and young enabling viviparity. One of those changes, for example, is the increase in or the elevation in oxytocin. And oxytocin is underneath one of the substances underneath maternal bonding. And that level of oxytocin is actually increased during the course of pregnancy itself. Neuroplasticity is required to make the newborn the most salient object to its mother. In fact, if you were to inject oxytocin to a non-pregnant woman, they will be searching out for things to bond with. We actually see this in rat models as well with the substance like prolactin, for example, where if you inject prolactin into non-pregnant rats, that's substance underneath the production of milk. They'll start nest-building activity too. So it's a really powerful substance. Oxytocin plays a key role in neuroplasticity, along with BDNF, brain-derived neurotrophic factor. But the oxytocin is a critical substance underneath the issue of attachment. The period after childbirth marks the time of greatest neuroplasticity, oddly enough, both for the infant, the neonate, as well as for the mother. So mother's brain is changing as well immediately postpartum. And neuroplasticity component of resilience comprises of two features. One is that resilience is integrative and regulatory. And second, that resilience is time-based. Next slide, please. So here's some of our own work on the subject. In the diagram, actually in the histology on the extreme, on your extreme left, of a 5-day-old infant, you can see a paucity of networking between individual synaptic endings. In a 6-year-old, there's an exuberant connectivity, and in an adult, it's actually pared down because much of what we already have learned has been automated as adults. 6-year-olds are learning everything for them is new material, and a 5-day-old hasn't developed the system yet. So whatever it is that's going on in the development of the system of a neonate and a fetus is highly prone to change as a consequence of neuroplasticity itself. Next slide, please. One of the effects, now we can begin, that's by way of background. Now what we can do is we can begin talking about the effect of chronic stress or allopathic load and its effect on dendritic endings, or dendritic connections. And what we see is that stress is highly associated with the expansion in the corresponding neurons, and it actually leads to shrinkage of dendrites, and therefore, as a result, the dendritic connections become statistically less likely to bond with each other. So learning is actually impaired neuroanatomically or histologically. Next slide, please. The Harvard group, the Center for the Developing Child, had actually done histology, it's kind of like what we had done, on the differences between toxic stress and normal situations. And here you can see in the prefrontal cortex and hippocampus, which has something to do with memory, as you all know, there are damaged neurons as well as fewer connectivities in the bottom portion of the slide under toxic stress as compared to normal. Next slide, please. Next. You can skip that. So let's get into the nitty-gritty of things. Next slide, please. Stress is the reaction that people have to excessive pressures or other types of demand placed on them. It arises when they worry that they can't cope. This is from the vantage point of Mama, and that is her allostatic load. Next slide, please. You can zip through this quickly. So the allopathic load is the wear and tear our minds and bodies experience as we attempt to cope with our continually changing environment. Again, if it's a high allopathic load, allostatic load over prolonged periods of time, there will be wear and tear on the system. Next slide, please. So, summarizing, stress occurs when the pressure is greater than the resource. Now let's get into the details of what we need to talk about. Next slide. There are a couple of things that we can say about the fetus itself. First of all, there's increased brain maturity, which is measurable. We measure it over time. So from 20 weeks, the fetus responds to light, sound, taste, touch, with increasingly complex movements. We can actually look at fetal responsivity on the basis of movement patterns, as well as being able to look at it through fMRI, which we can do by placing the woman's lower abdomen over a specially constructed unit. We can also look at it through 4D ultrasound. If cortical activity is used to measure consciousness, for example, then the EEG, the electroencephalogram, demonstrates that at 19 to 20 weeks of gestation, the EEG is already present. And we can study EEG in fetuses, and that's exactly what we're doing. Somatosensory evoked potentials can be recorded from about 24 weeks. That means, in plain English, that EEG activity that's computer average associated with somatosensory activity is measurable. And fetuses can acquire distinct verbal memories from prenatal experiences from about the 3rd trimester on, which continues to support that consciousness develops before delivery. And I'm not getting into political debates. Next slide, please. If we're interested in assessing fetal well-being and neonatal well-being, there are a number of ways that we can do this. One involves movement, as I've indicated, sleep states at their regular behavioral arousal, fetal oxygen and CO2 status, fetal progesterone and estrogen status, their thermal status of the fetus independently of mom, and the response to tactile stimulation, which we can do in vivo in the womb, which in fact we are doing. Next slide, please. Objectively, we can measure heart rate. Its normal heart rate of a fetus is between 100 and 140 beats per minute. Respiratory effort, whether it's apneic, irregular, shallow, reflex irritability response, muscle tone, whether it's flaccid or low tone, and whether the fetus is cyanotic or pink, but the color of the fetus. Next slide, please. So, the prenatal behavior of the fetus. Fetuses are capable of differentiating between familiar and novel stimuli between 32 and 33 weeks. Newborns can remember prenatal stimuli and react accordingly. In fact, a newborn can preferentially react and orient to mama's voice as compared to all others. Same thing is also true with music. The Mozart effect doesn't work, but there is a differential responsivity of a neonate to music that the neonate heard during the course of the mother's pregnancy. Very active fetuses tend to be active children who can be labeled hyperactive later on. So there's a lot we can learn about the fetus during fetal development. Next slide, please. So, is the fetus capable of learning? Important question, because if it is, then we can learn both positive and negative things. And yes, it's not always a value that we put on something. Next slide, please. So the answer is seemingly yes. Newborn infants have been shown to recognize rhymes and stories presented before birth. Newborns also prefer the smells, tastes, and sound patterns that are familiar because of prenatal exposure. Yes, the fetus can smell the amniotic fluid and can respond to tactile stimulation. We do this. Next slide, please. At 32 weeks of gestation, the fetus decreases responses to repeated or continued stimulation and a simple form of learning that we call habituation. If you take a look at the graph that's on there, anyone who's taken a course in Psychology 1, which I did about 60-something years ago, is a standard habituation graph. So they're capable of habituating to that which they've learned. Next slide, please. What are they capable of sensing? Next slide. Sensory structures are present pretty early in prenatal development. Visual experience is obviously negligible, but fetus experiences tactile stimulation as a result of its own activity. It tastes, it smells, and it responds to sounds from pretty much about the 6th month of gestation. Next slide. The nose develops, odors become available in fluids bathing the nasal cavity somewhere between 11 and 15 weeks, and structures of taste are completed pretty much by the 14th week, and that fetuses do swallow more with sweet taste, and these are not automatic responses, they are preferential responses of the fetus. Next slide, please. There's reactive listening after 16 weeks. Auditory structures are completed, the entire auditory system, by 24 weeks of gestational age. Mother's voice sounds better heard. That is, there's a greater recognition to mother's voice as compared to all other voices, and there's recognition and preference for maternal voice and known material. Next slide, please. As it relates to vision, the fetus is capable of avoiding attack needles for amniocentesis by about 16 weeks of age. Twins locate each other pretty easily after about 20 weeks. Gerard, you've seen that slide. Light sensitivity after about 20 weeks, opening of the eyelids about 26 weeks, and visual focus and follow-up for vertical and horizontal somewhere between 31 and 32 weeks. Next slide. Same with pain perception. Next slide, I'll just talk through it. That is, as it relates to pain perception, fetuses are highly reactive to pain. Whether they remember it or not is another matter. This now brings us into the next unit that I wanted to speak about, which is prenatal programming. What is the nature of life in the womb? What is the relationship between mother and the fetus? So our bodies are programmed in analogous and far-reaching ways by our experiences. Our experiences change brain state, and those changes occur prior to birth. And the events to which we are exposed as we develop our body's structure and functions during our life in the womb can improve or worsen on the basis of the fetus's relationship with its mother. So there are things that directly relate to the health of the mother and therefore the health of the fetus, one of which is blood pressure, cardiovascular health, eating patterns, and that we will be hearing a little bit more about later, and the tendency to weight gain. On the other end of the spectrum, on the behavioral end, there is emotional resilience, and we'll talk about why that happens, intelligence, and I don't mean intelligence as defined as the ability to succeed on an IQ test. I mean intelligence as defined as the ability to behave adaptively, the susceptibility to cancer and resistance to infection. And those relationships are intrauterine between mother and the fetus. Next slide, please. In short, prenatal programming affects every aspect of our physical and mental health at every stage of our lives and at every stage of fetal development. Next slide, please. So there are 10 principles that we can extract, and I'm putting them up as principles. We'll discuss them a little bit more at length, but I'm doing this in summary form. So the first is there are critical periods of vulnerability to suboptimal conditions for the fetus during development. By critical periods, I mean not just sensitive periods, but periods of that if something doesn't happen or goes somewhat amok during a particular period of time, it will have a permanent effect. That's different from a sensitive period, in which case, if something happens, you can probably recover from it. It may cause some damage, likely temporary. Secondly, programming has permanent effects. That is maternal programming during pregnancy has permanent effects that alter the body's response in later life and can modify susceptibility to disease. Third principle, fetal development is actively dependent. That means normal development is dependent on the fetus's continuing normal activity in the womb. If something goes wrong with development at that time, and we'll talk about why, it will have a permanent effect on the development of the fetus. So fourthly, programming involves several different structural changes in important organs of the body, and the placenta itself plays a key role in the programming, the behavioral and physical programming of fetal development. Next slide. Principle number 6. If the fetus needs to compensate, it's going to cost. So in unfavorable environments, the developing fetus makes attempts to compensate for the deficiencies, and it will cost the fetus in development. So attempts that are made after birth to reverse the consequences of programming may have their own unwanted consequences. Eighthly, excuse me, fetuses react differently to suboptimal conditions than newborn babies or adults do. So by studying or knowing something about a newborn infant, a neonate, doesn't necessarily tell you anything about fetal development. Ninthly, the effects of programming can pass across generations by mechanisms that do not involve changes in the genes. So we have an epigenetic effect in here as well. That is what the damage that happened in one generation during a pregnancy can actually make its way into the fetuses of the grandchildren. We'll talk about that. And programming has different effects in males and females. There are gender differences or sex differences in how fetal programming occurs. Next slide, please. So, the first principle. There are critical periods when certain parts of the fetus are vulnerable to stress from exposure to toxins or from lacking nutrients or lacking oxygen, but certainly from stress as well, from allopathic load. Cells have to make a fundamental choice between growth and specialization. And if growth is compromised in some way, as it will be in the case of stress, because there's more oxygen that has to go to the brain as compared to the rest of the body, then specialization, cellular specialization will be affected. And these, in fact, growth and specialization can become competitive with each other, and each cell has to make a choice to divide or specialize at some point, and the process is irreversible. Next slide. Some types of cells, like nerve cells, never divide again after they specialize. So there's something that we can say about how nerve cells develop, and bear in mind that from one cell at fertilization, 1/175th of an inch in diameter, to birth, roughly 60% of total cranial capacity, and about another 20% kicks in by the age of 2, we're talking about a significant effect. So some types of cells, like nerve cells, never divide after they specialize. And it's important that each developing cell make the right decision at the right time. And if a decision is made too early or inappropriately, or at the expense of one part of the body over another, an organ will end up with too few cells and thus be unequal or inappropriately prepared to the challenges of later life. Next slide, please. Second principle. Programming has permanent effects. When nutrition is deficient in the womb early in gestation, cells divide less frequently, and that results in fewer total cell count in the fetus. So, this fetus would be overall smaller, but the body parts will be proportional relative to normal, and that's known, we call that symmetrical growth retardation. However, when stress or allopathic load makes things more difficult in the second and third trimester, the cellular community of the growing fetus prioritizes which nutrients and where those nutrients will go. Next slide, third principle. Second principle. Since the brain is the organ most important for survival, both inside and outside the womb, the largest share of blood, nutrients, and oxygen needs to get routed towards the head. So as a result, there's going to be an effect on other tissues of the body which won't grow as they should, and that leads to a newborn with a head that's slightly large in comparison to the body, and that's referred to as asymmetrical growth. There's a local pediatrician who is a clinical researcher who has been measuring the circumference of babies' heads and has found that associated with stress, there's a tendency to larger heads, and that in turn has a tendency to be associated with children on the autism spectrum. Not the point of our talking about it right now, but need to bear that in mind. Next slide, please. We have recently found that not only did girls who were born with low birth weight have a smaller final stature when they had grown to their full height years later, but they these girls reached sexual maturity roughly about 1.5 years earlier than girls with normal birth rate. And that probably makes some degree of evolutionary sense, because it probably will have, if you're subjected to stress, maybe associated with famine, the likelihood is that you will need to reproduce early because you'll probably have a higher mortality rate. Next slide, please. The third principle, fetal development, is activity dependent, which means you move. And we have that in adult life as well. You don't move, you lose it. So fetal development is activity dependent. The fetus must use it or lose it. And the way that fetal cells develop depends on how the fetus is using its body. The fetus is able to swallow and suck at birth because he's practicing or she's practicing and swallowing the amniotic fluid that bathes the fetus in the womb. And the nerve cells in the brain wire up correctly because signals are running through them, testing them throughout the whole time they are developing. This may, in fact, have something to do with the concept of failure to thrive. Next slide, please. The fourth principle, we know that programming involves structural changes in the development of the internal organs of the body other than the brain. And one cause of the structural changes is the altered growth of blood vessels in the challenged fetus. As we had indicated before, if you're going to have to send more oxygen to the brain, then there's going to be less oxygen available for the growth of the and other organs in the fetus. So if an organ developed too few blood vessels in utero, it'll be harder for the body to increase the blood supply to that organ during times of need later on in life as well. This is what psychologists actually, if I'm not mistaken, had spoken about a predilection for disorders of certain organ systems on the basis of cognitive load. That is, you pick when you're under stress, you pick the organ system most impaired or most likely to be hyperreactive. And so that's why some people suffer with stomach aches versus breathing problems or other matters. Next slide, please. One example of a structural change is fingerprints. Without getting into this, we can do the next slide. I can tell you that the fingerprints are not determined genetically. They're largely determined by things that can associated with allopathic load. That is, you can see the difference between fingerprint with whorl patterns versus non-whorl patterns. That can change as a consequence of stress too. But that would be an example of environment manipulating something physical. Next slide, please. Principle 5, the placenta is crucial for the development of the fetus for more than the obvious reasons. First of all, obviously, it's the bridge between fetus and mother. Sorry for the misspelling. The fetus's placenta not only acts as a gatekeeper for everything that comes in, so it actually filters out toxic substances as well, but it's an important hormone-producing organ in and of itself that affects the way the mother and fetus change physically and cognitively, and that oxytocin production has something to do with maternal bonding. So the state of the mother has a lot to do with bonding. And so difficulties in bonding postpartum for the female have a lot to do, not in all cases, but not in an insignificant number, not insignificant number of cases, have a lot to do with how it is that mother bonds with child. Next slide, please. Compensation is yet another principle for shortcomings during development, and that, of course, has a cost. An example is how the fetus digestive tract and liver are affected by detrimental conditions. Because most of the baby's waste can be processed by the mother, or at least the mother's liver, and glucose comes across the placenta all the time from mom, the fetal liver operates at less than 100% efficiency until after birth. Next slide. So when oxygen or nutrients are low, the fetus tries to adapt. The fetus deprives the unessential organs of blood, sending the majority of the blood supply to the essential organs. However, the rerouting of blood away from the liver forces the baby to grow a small liver. What is the effect of a small liver going forward? The organ continues to function less optimally than it should throughout life. And that then, next slide please, that then is associated with problems with cholesterol, with adult type 2 diabetes, adult onset diabetes. Next slide please. Seventh principle, we attempt to reverse this medically. That is, can we reverse programming after birth? Well, yeah, and it has unintended consequences. And this is because so many of the decisions that cells make are done in utero, and they're irreversible. So for a baby who had little food during intrauterine life, she may not be able to cope with plentiful, rich foods afterwards, and will have a significantly greater likelihood of becoming obese. In animal studies, food restriction during prenatal life actually led to a shorter lifespan. Next slide, please. Fetuses also react differently to suboptimal conditions into adults. Fetuses are just as malleable as we are. So growing cells need more oxygen, amino acids, vitamins, glucose than those that are not trying to expand their activities. So small shortages can actually kill cells during development, fetal development. And these may in fact never be replaced. Next slide, please. Ninthly, the prenatal effects may carry from one generation to the other. And this is kind of not exactly intuitive. For example, if the developing fetus is female and has a compromise leading to smaller organs, when she becomes an adult and she in turn becomes pregnant, those smaller organs may not be able to keep up with the demand, and that in turn will affect the fetus. And that's one of the reasons that this stuff crosses generations. Another example would be that if there was blood sugar problems during a pregnancy, damaging the blood sugar regulation in the female fetus, this could lead to the same problems during her pregnancy as an adult, and so on through the generations. Next slide, please. So, Finally, as it relates to these 10 principles, programming is different in male and female fetuses. Boys and girls grow in slightly different hormonal environments. These differences are subtle but may play a major role in behavioral and other functional differences between men and women much later on in life. Next slide, please. So, the fetus keeps tabs on its own energy supply. If there's a shortage, the fetus learns to prepare for the shortage and how to cope with it later. The fetus also monitors its mother's stress level, and high stress hormone levels will make the fetus hypersensitive to stress hormones postpartum. And important for the mother to monitor her own stress levels, and this is not done clinically. What needs to actually happen is blood cortisol needs to be taken from pregnant women on an ongoing basis, and it's not. Next slide, please. Stress in the womb then puts the pregnancy at risk. Lifelong effects affects the child's temperament, makes the child overreact to stress, and make the child more susceptible to depression later on in life. Next slide, please. People under stress don't eat well. They either eat too much, too little, or wrong. Our body's response to stress by releasing cortisol and other hormones. And with stress present all the time, the individual will have a higher than normal cortisol level, causing the fetus to be hypersensitized to stress. The child, the neonate, is then more likely to be unable to concentrate, leading to learning difficulties. Next slide, please. One of the effects is premature delivery. So when the baby finds that, when the fetus finds that there's no more room to grow, or when there is a lack of food or oxygen, stress hormone concentrations in the fetus's blood may rise, and that would stimulate the production of estrogen and therefore the beginning of labor. And if the mother is under enough stress, if there's a high enough allopathic load, her increased production of androgen may cause the level of estrogen to rise a whole lot sooner than it should, and that would initiate a premature delivery. Next slide, please. So, our basic model that we've developed until this point is thus. Stress and anxiety in pregnancy is associated with elevated cortisol in mom. Cortisol is transmitted to the fetus, either directly or indirectly, and that's independent of the placenta. Cortisol exposure during this sensitive period has a direct effect on fetal brain and mediates the link between prenatal stress and infant outcomes. Early exposure can program certain systems, suggesting long-term effects on behavior, as we've seen, certainly immune reactivities and fear reactions. And postnatal factors can moderate the effects of prenatal exposure, but only up to a point. Next slide, please. So, very quickly in the 3 minutes here, there have been 3 major studies, large-scale studies, one at Imperial College London, and these studies were based on at an amniocentesis clinic, and only mothers with normal pregnancies and babies were included in the study. The children were assessed again at age 17 months, and detailed assessment of the HPA axis, which has something to do with allopathic load and stress, cognitive ability and temperament were measured. Next slide. The findings are in your face, kind of. The stress, anxiety, and pregnancy is associated with elevated cortisol in the mother. Next slide. Maternal plasma and amniotic fluid cortisol are moderately positively correlated with activity levels in the infant postpartum. Next slide, please. There's evidence to support that there's something particular about prenatal stress exposure, and here we can see the relationship between the number of postnatal stressful life events. Prenatal versus postnatal. Prenatal on the left, postnatal on the right, as it relates to the Bailey scales of infant development. Next slide, please. So prenatal exposure to cortisol predicts lower cognitive ability at 11 months, also part of the Imperial College study. And the next slide. And the association between prenatal exposure to cortisol and lower cognitive ability is moderated by early rearing. Same idea. Next slide. In the second study, this was a longitudinal prospective follow-up of 6,500 15-year-olds on whom prenatal stress, anxiety, and detailed developmental data were collected from pregnancy. And age 15 assessments included in-person psychiatric assessment and diurnal cortisol. Next slide, please. And here we see the same relationship. There's a relationship between prenatal stress, which is associated with elevated cortisol at age 10 and a half. So what happens during the fetal period actually has carryover during early child development, at least until about 10 and a half years of age. Next slide, please. And here we have the relationship between prenatal anxiety predicts behavior emotional problems. Yes, true, there's a confound in here because an anxious mother who is pregnant would likely still be anxious after the pregnancy as well. But the data does hold up. Next slide, please. Thirdly, the Rochester studies, and then this will be finished, was an NIMH-funded study of about 200 women from an obstetrics clinic. Next slide, please. And generally speaking, the findings are pretty much consistent. A reliable association between maternal prenatal and stress levels and pregnancy complications, obstetric outcomes, cognitive development of the neonate and child, behavioral emotional problems, and indicators of neurodevelopment, which includes atypical laterality, agenesis of the corpus callosum, dermoglyphic asymmetry of the finger ridge counts, autism and schizophrenia, persistence of effect beyond middle childhood, and controlling for postnatal anxiety stress. Next slide, please. So, we are hopeful for a global community of healthy children, and toda rabba, thank you very much, muchas gracias. Take care.
Thank you so much, Dr. Leisman. Absolutely fascinating. Actually, thanks to your presentation today, I understand why, as a clinician, we always say the treatment on the specific of every patient is different. And things don't happen the same way for two different people. And now I understand why. Because two different people have not been exposed to the same prenatal exposition. And that's very individual. So, and also I guess that if a woman is taking some anxiolytic and be treated because she has too much anxiety and she needs some medication, I guess that can affect also the child. What is your point of view, Dr. Leisman?
Certainly, yes. In fact, there's a dynamic relationship between mother and fetus, and in part, in a large measure, it's through the placenta. But in large measure, it's not, because the placenta itself can produce its own hormones. And we see that both oxytocin and cortisol can be mitigated by the fetus itself on the basis of its own need. The fetus does respond to stress and its own stress. If the fetus is in a stressful environment, there will be long-term effects, as we've already indicated. And those effects are not just postpartum. Those effects are pretty much lifelong.
Thank you so much.
Well, what's underneath that, just to close the point, is essentially it's the issue of brain-derived neurotrophic factor, which is the substance underneath neuroplasticity, which in stressful environments is reduced because you don't need to learn new things. You need to take whatever resources you have and get out of the situation you're in.
Thank you so much. Actually, this is so interesting that we already have planned to organize a webinar for the people who are interested, because it's really something which is so interesting that we need more time to be able to better assimilate it. So we asked Dr. Leisman to conduct for us a webinar, so we could go deeper. With that said, thank you so much, Dr. Leisman. I will ask Dr. Wallace to now present the result of a study which have been made.
Thank you very much, Dr. Leisman. I really appreciated everything that you shared with us. So just a little bit of background. I'm a clinical psychologist. I've been in the field for 20 years. I have a background working in Chicago. I moved to Israel about 6.5 years ago. I work as a clinician primarily, but I'm also now involved in research as well. I use a variety of tools. My background is really in cognitive behavioral therapy. I've been trained in biofeedback and relaxation training. I've worked in chronic pain management, and I've worked with people with chronic health issues from cancer and migraines to other issues like gastro health. And now I'm also working as well with a number of pregnant women as well. And so I think that it's really important to know how a woman's mental health status and stress and anxiety can also impact the fetus and fetal development, but also post-fetal development of issues as well. Next slide, please. We did a study looking at a treatment using sound to help people that is not medication, it is not therapy, in terms of not traditional psychotherapy where it's involved with talking, which typically involve a lot of time. Medications all have side effects, but also take time for them to become effective. Therapy itself also takes a long process. And we looked at what's called the binaural pulse modulator. Also, there's a BAW, or the binaural utilization device, and we did a pilot study looking at sound to treat stress and anxiety. Next slide, please. Next slide, please. There we go. So we're looking at stress or distress, which is a negative response. Back one, please. Distress is a negative response, or a response to internal and external triggers. It could be emotional, social, spiritual, or physical triggers that are causing a person to then feel sad, afraid, depressed, anxious, or lonely. And these are all stressful experiences. And when people feel distress, they may feel that they're unable to cope with the situation that is triggering the response. And normal life activities or disease can be triggers as well. And so the psychological stress can often have non-specific patterns, symptoms like stress, elevated heart rate, blood pressure, changes in cortisol, elevations in cortisol, adrenaline, anxiety, depression. And we're looking at the impact of, we looked at the impact of the stress and what we could do in an additional tool to help people that does not require something that may have side effects. And particularly for people who are, for women that are pregnant, oftentimes they will not be allowed to take many types of medications during their pregnancy, or they won't start medications for stress or depression. Next slide, please. So the binaural pulse modulator is not biofeedback or neurofeedback. It's using sound. And sound has been used in healing going back hundreds, if not thousands of years, from shamanic healing rituals in the United States, as well as in healing rituals in the Far East as well. And the binaural pulse modulator, the BPM, it stimulates aspects of the nervous system through sound, through the auditory system. So it's not biofeedback. We're not monitoring and giving back, and the person doesn't have to do any training. The treatment or listening to the sound, it's self-directed, self-controlled. And the therapist, then, although initially present and has more of a training of how to use the device, really the patient themselves uses the device for reducing their stress. And so we wanted to see if this is something that is effective. And it's a shorter intervention. There's no conditioning or learning or retraining. There's no medication, so really no side effect. Next slide, please. And so with the binaural beats or frequency or pulses, we're listening to sounds, to tones that are presented, one to each ear, separately. So the device itself, as you can see in the picture on the part of the screen, and the main knob is for on the bottom part of the device. And those allow you to separately control the volume for each ear. And then you have the main frequency, which controls a frequency of tone between 0 and 330 hertz in both ears. And then the secondary control, or the disruptor, controls a secondary level on the left ear only, increasing that from 1 hertz above to up to 20 hertz. And this difference between the two sounds that's perceived by the brain is called the binaural tone. Next slide, please. So what we tried to do is to determine if this tone would be effective in alleviating symptoms of emotional distress in a group of 60 participants. We ended up with 59 in the data set. And we collected the biological data as well to determine how this affected the brain as well. And we looked at a protocol where we did a pre-test, then we had a baseline, and we treated people with 2 sessions a week between 15 to 20 minutes, twice per week for 4 weeks. Next slide, please. And we assessed each of the individuals for anxiety, post-traumatic stress disorder, depression, or high levels of stress. And we found it to be effective, and we'll get to that in a minute. But we looked at 4 different treatment groups. We looked at the treatment using the auditory or the sound therapy. We looked at treatment as usual, whether it was psychotherapy or medication. So this does not include a group of women who are pregnant. A sham sound, where people were not listening to this sound where there's the difference between the 2 ears, or also weightless control. Next slide, please. And we assessed people looking in an ongoing way, looking at their anxiety using the GAD-7, which is the generalized anxiety disorder. It's been used for years now. We looked at the COVID stress scale, which is a new measure. And then we also looked at a post-traumatic stress disorder scale, or the PTSD checklist, for the DSM-5 or the PCL-5. People completed these measures before they started the intervention and at the end of intervention, and also 4 weeks and 12 weeks later. Next slide, please. And what we also looked at was in the subgroup, we looked at 4 people, 3 from the active treatment group, and then 1 control looking at fMRI and also at qEEG data. And what we found is that there was a significant change in people's self-reported level of PTSD and in stress from before the treatment to after the treatment. It was effective in reducing anxiety, PTSD, panic, obsession, and high degrees of stress. And we also found significant results looking at the brain, both on the qEEG data, comparing the treatment group of 3 to the standard or the control, and also looking at the fMRI. So we see how there was a change, and this again is something where there's no side effects. So for women that are pregnant with high degrees of stress, okay, one potential treatment approach that we can now add to the tools here that they can use would be treatment using the BAUD or the BPM or sound therapy to help reduce their levels of stress. Okay, and hopefully we can then use this to mitigate or to offset the negative effects on fetal development and post-fetal development as well. And although we haven't published yet, we've submitted already, and we're hoping to be approved, but we had significant results. And the first one that was submitted was actually the smaller group. We're looking at the physiological data.
Have been approved.
Okay, and so it's to be published soon then. And the second study is looking at the subjective data, and that also we're looking to see, and we have seen effect for people to reduce their level of stress. And again, so the implication here is that we have a tool that we can help the pregnant woman to reduce her experience of stress, okay, through sound therapy, okay. And if this is effective, we are hoping to see also the beneficial results on fetal development as well. This is, I guess, a future study to be seen, but the first part is reducing stress in women who are pregnant. Next slide, please. And so here we see the changes in the brain. And again, we're looking at the slide, looking at baseline to the after the treatment. And we can see that there are significant results where the brain is lighting up differently on the fMRI. So the blood flow to the brain is clearly changing through the treatment and over the course of treatment. And so this was after 4 weeks, twice a week, 8 sessions of 15 to 20 minutes. So we're not taking something that's very time intensive, and hopefully will be something that people can really apply in their day-to-day life, and maybe even have a stronger result if they use it more frequently. Next slide, please. So with the increasing demand that's on the health system in general, we're trying to provide a tool that people can use, not just only in their doctor's office, okay? In the beginning, it might be in their doctor's office or in a therapist's office, but over time, this is something that somebody can then use on their own to manage their distress, reducing the effects of medication side effects or long wait times and high cost on the medical system, and also time that maybe many pregnant women don't have to go running around to see more doctors more frequently, to try to reduce their stress. Again, no side effects, and so we can try to reduce the impact of stress on the pregnant woman and also on the fetus. Again, if we can reduce and have an intervention that reduces anxiety or stress during pregnancy, that doesn't have the side effect possibilities that come along with any medication, to me, that sounds only like a good thing that we can provide. Next slide, please. And so the device, as you can see, is pictured here a little bit larger. If you have questions, please feel free. You can send inquiries to get more information at info@bodbpm.com. But if we can provide something to help somebody reduce their experience of stress, which would hopefully have the beneficial effect, we're happy to try to help people.
Thank you, Dr. Wallach. Obviously, we are talking here today because of the presentation of Dr. Leisman about anxiety and high stress during pregnancy. But the board works for every type of population. But we are developing, implementing it in Israel with a special focus on in pregnancy, because we have a group of, we are different cluster in Israel where there is a high rate of number of children per family. So it's really a country where we can see the result, and there is also a high rate of anxiety as well. So thank you so much, Dr. Wallach. Now we are asking Dr. Hillel Broad to present what he is doing.
Hi, everyone. Can you hear me all right?
Yes.
Okay, great. Thank you. So I'm so happy to be here. I'm sorry I wasn't able to be present for Gerry's presentation. I just got the tail end of what seemed to be a really wonderful presentation. And I'm looking forward to reviewing the video of the presentation. So I've been asked tonight to present a brief presentation on working with pregnant women using the Feldenkrais method. Some background about myself: I'm a medical doctor, a neuroethicist, integrative medicine doctor, and I'm a founder director of the Somatic Well Center, providing integration of therapies for neuroplasticity, regulating the autonomic nervous system, neurotechnologies together with somatic practices. And more recently, I'm very delighted to be partnering up with the Mental Wellness Association and the M3, the new M3 centers that are developing. Okay, here's a slide you can see of a presentation I gave a number of months ago for a conference supported by the Weizmann Institute, which was looking at movement and the brain, and also been associated with Gerry's Mind and Cognition Conference, and that's how I met Gerry and Gerard and Joseph, and part of this developing network. So I work, so the term somatic is basically a term for the first person experience of having a body, working with a body. I work mainly with the Feldenkrais method, but I also work with other modalities such as body-mind centering, continuum, and a host of others. And one of the ways of, thank you for the slide, Celeste, one of the ways of thinking about Feldenkrais work is as a kind of practical psychophysiology. Okay, so that's why it really fits well into the Mental Wellness Society. So traditionally, Feldenkrais work is divided into awareness through movement lessons, which are group structured, choreographed, slow movement lessons, and then one-on-one individual work with functional integration. So some of the principles of working with the Feldenkrais method as a form of practical psychophysiology, which are key to regulating the autonomic nervous system, for reducing stress, improving well-being, mental and physical well-being. So for example, in an awareness through movement lesson, a guided lesson, the tone of the instructor's voice is very important in terms of the prosody, in terms of helping individuals to regulate their autonomic nervous system. The idea of awareness, of moving with awareness, as opposed to just moving. Okay, so for example, I could invite you to do something like this. If I invite you to lift your arm up, I'm lifting my left arm up to the ceiling. Now you can imagine lifting your left arm up where you're initiating the movement with your fingers, okay? Or you can imagine initiating the movement from your shoulder joint. So if you want to do that, you can just try it. Now, to an external observer, it's exactly the same movement, right? The arm is lifting upwards, but to experience it, it's a completely different movement if you are directing the movement from your fingers or if you're directing the movement from your shoulder joint. So that's an example of moving with awareness. And so the next point is slowing down. Once you slow down a movement and once you bring in awareness, you're immediately into the realm of brain neuroplasticity, where you are laying down new neural pathways. So it's not, a lot of people think Feldenkrais is physical exercise. It's not. It comes out of the history of the somatic practices, which came out of the German anti-gymnastica method movements in a way, which was kind of not doing exercises, but moving with awareness and kind of backgrounds in modern dance and things like that. So slowing down the rhythm is really important if you want to start looking at how to create new neural changes, how to break out of fixed patterns, both physical and mental patterns. Also, the head-pelvis connection is really important. So, for example, I was reading a book the other day that in our neck we don't actually the first somatic nerves aren't actually S1 isn't it S1 C1 or just trying to think doesn't actually register the dendrites in the skin. Okay, so the whole tone of the neck muscles are internally directed and set the whole pattern for the whole nervous system all the way down to our tailbone and beyond. So the head-pelvis connection is really important. Movements from side to side are really important in regulating the autonomic nervous system. So these are all principles which I use in terms of teaching Feldenkrais lessons, which are directed specifically for regulating the autonomic nervous system. But there are thousands of variations and possibilities, and which have different effects depending on the choreography of the lessons, the structure of the lessons, and an intentionality of the teaching of it, which is really important. Neural oscillations is really important. Every movement lesson is a kind of a movement in brain oscillation, because every Feldenkrais lesson or every movement is a toing and froing, a coming and returning around a central axis. And when you start keying into the oscillatory nature of the lessons, you start moving into the territory of neural oscillations and the ability to create new dynamics in the nervous system. So these are just kind of 5 principles, but one could really expand them quite a lot into different fields. Okay, if you can, Celeste, if you can just look at the next slide. So because of the initiative of the M3 Center on focusing on working with pregnant women, so I suggested to teach a series of lessons which are called pregnant pauses. Each lesson is called a pause. Essentially, they're Feldenkrais lessons, but they've been devised specifically by a senior Feldenkrais trainer called Alan Questel for working a series of 6 lessons for working with pregnant women at all stages of the pregnancy. Okay, and the idea of teaching these lessons in the M3 Center is that you don't need to teach 100 different Feldenkrais kind lessons. You can just teach a handful, 6, right? And go over them at different stages of the pregnancy, and which will have phenomenal effects in terms of physical and mental well-being for the mother and for the developing fetus, in terms of reducing stress, reducing anxiety, improving the breathing, improving the elasticity of the ribs, improving the elasticity of the hip joints, and now in a clinic that I work, integrative medicine clinic, I meet a fair amount of women in different stages of pregnancy, and very few of them are continuing to do exercises, particularly in the more advanced stages of pregnancy. But it's really possible to continue moving and doing gentle movements at all stages of the pregnancy. So, for example, all of these 6 pauses predominantly focus on lying on one's left side. So there's no lesson which is lying on one's right side, which is sort of contraindicated or relatively contraindicated in later on in pregnancy. One can lie on one's back if one's comfortable or not, but certainly in a more advanced stages in pregnancy, you don't want to be lying on your back. You can just lie on your left side. So it's completely safe at all stages of pregnancy and completely doable. The 6 lessons are different ways of rolling. The second lesson is called pressing and lifting. And that's also a lesson on one side. Finding ways to turning. And also lesson number 4, gentle fingers, gentle threads, is a really interesting lesson where you're moving, for example, either your pelvis or your sternum in the front, or your back at the back, or your pelvis in the front at the back, and imagining whether you have a thread which is pulling you or whether a finger which is pushing you. And it's similar to what I was saying with lifting one's arm, depending on how your intentionality of the movement, you'll have very different experience of the lesson. And they're all fabulous lessons for reducing anxiety, for increasing ease of movement. And what's great about it is that the more you do them, the more you realize how you can apply the fundamental insights of the lesson in one's daily functional activities. The 5th lesson is your pelvis and breathing, and that's a lesson essentially sitting or else lying, resting on one's arms and forearms, and coordinating different kinds of breathing, and including Kegel exercises for strengthening the pelvic floor muscles. And the 6th lesson is you're starting with rolling in a different way of rolling from side to side. So those are the pregnant pauses. I'm licensed with Alan Questel to be a teacher of the pregnant pauses, and very happy to have the opportunity to be teaching these series. Also to say that I'd be also interested in looking at other ways of working with pregnant women for creating greater ease in pregnancy and greater mental and physical well-being of mother and baby during pregnancy and post-pregnancy as well. Okay, we could move on to the next slide. And so the possibilities of teaching pregnant pauses or Feldenkrais lessons could either be online, in person, or in a group, or else directing an online group through the M3 Center, and possibly in Israel as well. So yeah, there we are. If anyone wants to reach out to me, I'd be very happy to be in touch. And again, thank you for this opportunity to present and to be part of this dynamic, amazing initiative.
Thank you so much. So, Dr. Leisman explained how toxic, dangerous can be anxiety from the mother on the fetus. Dr. Wallace explained that there is an apparatus, handheld sound therapeutics system, which can help to diminish or even eliminate the negative side of that anxiety. Dr. Hillel Broad explained us that there is some movement, and obviously he's talking about putting the mind into the movement, not having the movement and then trying to do it by automatism, but to the contrary, he's talking about, again, putting the mind first and having a coordination in the awareness between the movement and what you want to achieve. Now we will be showing another modality, which is the intake of the mother, because we are talking here about with the Dr. Justin Friedman. She's from South Africa, as well as Dr. Broad, and she is a dietitian, but she specializes in mood and gut relation. And she prepared actually something. She cannot come be with us tonight, but she made a video for you, especially for tonight, explaining the importance of a proper diet for the mother during pregnancy, and including reducing stress. Okay, let's play the video.
Thank you so much, Gerard, for inviting me to speak on this panel. My name is Justine Friedman, and I work as a clinical dietitian and a mindset mentor. The needs of a woman going through pregnancy are increased compared to normal daily living. And one of the concerns that many women have, pregnant women have, is the changes to appetite that can occur, which may inhibit them from fully being able to eat according to how they would like to during pregnancy. Added to this, some great anxieties that may be present due to needs perhaps for amniocentesis or changes in their body that they are not used to, the unexpected outcome of which they are not sure of, are all factors that play a role with the choices in nutrition that women can have. One of the common complaints that I see with clients coming to me is the changes in taste and the aversions to certain foods, which can also inhibit them from eating well. And one of the main areas that they would like to be taking care of themselves and their future baby during pregnancy is in order to be able to nourish themselves correctly. Many women find that during pregnancy, their own needs almost come second to what they would like for their baby. The actual nutrition needs for women that are important to pay attention to during these months of pregnancy, and sometimes even before in preparation for pregnancy, are in order to be able to ensure that their folic acid is high enough, iron levels increase during pregnancy, the need for omega-3 fatty acids increases, as well as protein, specifically protein from the second trimester and onwards. And these are all nutrients that can be obtained through foods, but oftentimes they are supplemented as well. What I see as common anxieties during pregnancy are often due to morning sickness, due to the rise in progesterone levels, and this can hijack their eating and make them feel unsure of what to eat, because so often the nausea causes a problem with food choices, and the traditional foods that women then start going for are very dry carbohydrate foods, crackers, toast, cheeses, which they can stomach, but may not always be the most nutritious for their bodies. From an anxiety point of view with pregnancy, the changes that can happen can also be physical, like constipation being a concern. That can add to worry and frustration. Sometimes normal fiber intake doesn't do enough to assist for them to really feel that they can get their stomach working okay, and they need to take supplements for that. oftentimes reflux or heartburn can also be very uncomfortable, specifically towards the end of the pregnancy. And one of the areas that I like to focus on with my clients who are going through pregnancy is to ensure that in order to reduce the anxiety that they are experiencing, that they are making the most nourishing choices possible within the scope of what they can handle. So what we focus on is foods that are the most nourishing for the gut, because we know that the gut microbiome is essential in assisting with health in the body in general, and it also affects mood. So when we have a gut microbiome that is experiencing dysbiosis, which means that it is not in balance, the good bacteria that we want to proliferate are in smaller quantities, smaller amounts, as opposed to the bacteria that are not as beneficial. What happens is there's a reduction in serotonin levels, and this then affects levels of their mood, which then predisposes them to anxiety and depression. So foods that boost a healthy and robust gut is essential in general for health, but specifically in pregnancy. So some women are not able to get sufficient probiotics from their diet, and in those situations I encourage a probiotic supplement, and this is something that they would need to also just run past their doctor and make sure that they're comfortable with it as well. In general, probiotics are safe, although we don't always know from all the different ranges out there which are the most complete. So in general, I would suggest something with lactobacillus as well as bifidobacteria. Those are two of the main ones that are very good for promoting good gut health. And then to encourage good fiber intake in order to be able to feed the good bacteria in the gut. Other areas that could be a concern with pregnancy are the risk of gestational diabetes, and clients who come to me who have destabilized blood sugar levels during pregnancy, then we work on how best to eat in order to reduce the glucose spikes after meals. So this is another area of anxiety that can occur, as well as a client that I'm working with currently who has ulcerative colitis, and it's caused changes to her inflammatory cycle. So also focusing on gut health is a priority for me when I'm dealing specifically with clients who have also coexisting conditions or are at risk for other conditions during pregnancy. So the main focus is ensuring that they have enough water in their diet, 2 liters on average, in order to ensure that they are not dehydrated. Good sources of probiotics, whether it's in supplement form or through foods as well, which are generally from fermented foods, as well as foods that will then nourish the gut and enhance the proliferation of the good bacteria so that we can increase serotonin levels, which then has a positive effect on mood, on levels of anxiety and depression. Obviously, there's the whole mindset aspect to that, which I also do discuss with my clients. And other nutrition advice that I give is to ensure that they are following as closely as possible a Mediterranean diet approach, which is high in omega-3s, which has good sources of protein, whole grains, and the main focus of the omega-3s in this diet is the things like olive oil, olives, walnuts, chia seeds, flax seeds, some of the other nuts and seeds as well, good sources of fish like salmon, the fattier fish. In general, we also encourage good sources of foods like eggs, as well as calcium sources in dairy products in order to ensure that they are getting enough iron, enough calcium in their diet as well. There's a lot of other supplements that doctors would look at, but in general, I would say that a woman who feels confident in the food choices that they're making during pregnancy will also allow them to have a lower level of anxiety going through the whole process. confidence, about knowing what to choose, about how to manage symptoms if they have morning sickness, if they are experiencing heartburn, if they are experiencing any gastric disturbances like constipation as well, so that they really feel as supported as possible during this process in order to ensure that their anxiety levels, their stress, their worry is as low as possible. Thank you so much. If there are any questions, I'm happy to respond to those. And thank you for inviting me to speak.
Okay, so time for us to close. Number one, you have seen different of our members. Dr. Leisman and myself, we are co-founders of the Mental Wellness Society. The Mental Wellness Society is now over 1,800 members in 72 countries. And we are welcoming specialists and experts of all aspects of wellness. So we have 5 groups: research, development. We have another group which is about education, parenting, a group of agents of change for corporation, a group of health and wellness and fitness, and a group of psychology. All the experts you hear today are part of the Mental Wellness Society, and it just happened that this group, is also involved in the Mind, Movement, and Mood Center that we are developing in Lincoln, Nebraska, where they are all providers online from Israel for a center in Lincoln, Nebraska, but other members of the Mental Wellness Society are also providers of their own specialty in that center. Dr. Leisman is not a provider, he is our scientific advisor, and he's helping us to steer us in the right direction to make sure that we don't commit ourselves with anything which could be questionable on a scientific point of view. Dr. Leisman, I will give you the last word for closing this meeting, please.
Well, I'm extremely happy to have participated in this meeting for a number of reasons. One, the issue of mental wellness is usually associated with effectiveness of life, with post-divorce issues, with child-rearing practices, with autism spectrum disorder, with all of these wonderful things of life itself. But we don't actually consider what happens before life itself, because we think that life itself starts at birth. Well, it doesn't. It actually has a lot to do with what controls the division of cells, how the embryo develops into a fetus, how it reflects evolutionary development, whether there are moral, ethical, or legal issues about it is irrelevant to the concept of physiological and biological processes in development. So what our job is to find out what it is that impacts on effective neurodevelopment and to ensure that babies are born healthy. For that to happen, we need to take a whole lot greater care about how it is that that an infant's mother spends her gestational life. That is the gestational life of her fetus. And to do that, we have to understand what toxic effects, or potentially toxic effects, the environment has, the maternal environment has, and the fetal environment has to long-term growth. This is something that really is not taken into consideration very much both in well baby clinics and certainly not during fetal development, during the pregnancy of women. Hopefully, this is the start of being able to have healthier babies. So thank you for the opportunity for making this happen, and hopefully we'll be able to distribute this information base and much larger audiences. Thank you so much for
We can even meet in person on the conference we are organizing next November 2023 in Tel Aviv. about resilience on all aspects of resilience, because it's very relevant to the panel of tonight. Thank you so much, and have happy holidays, all of you. Thank you so much. Be well and happy.